Yeah, so welcome to this course on DME and PDR with Neeraj, can you please join us? With simplified algorithms from basics to 2017. So we have this course which is rated 125. I have stalwarts who need no introduction, and we have given you algorithms and a feedback form, and I request you to fill up the feedback form, give us suggestions so that we can improve on the course subsequently. Please leave it with the volunteer who will be standing outside. Professor Atul Kumar needs no introduction. He has been our guide for many years, guiding us in various ICs and multiple forums with many teaching tips he has given us. He is the chief of RPC, professor of ophthalmology in retina, vitreous and uvea, and he is also the coveted Padma Shri awardee. He will be talking in anti-VEGF and DME and PDR. Professor Vishali Gupta, who is professor of ophthalmology and retina vitreous at PJ Chandigarh. She will be talking on lasers in DME and PDR and the role of steroids in DME. Dr. S.P.S. Grewal has been my guide and mentor. He is director of Grewal Eye Institute and visiting professor to the NW University in Chicago, USA. He will be talking on cataract surgery in DME and PDR, timing technique and choice of IOLs. Manish is a great friend, and when you are friends, you also teach each other a lot. He is director of the Retina Foundation, and he'll be showing you his beautiful videos on vitreoretinal surgery for DME and PDR, indications, timing and technique. Neeraj and I are partners, and we have had a lovely relationship for relationship means partnership for last almost 11-12 years. And he is director of Delhi Retina Center, Vian Center in Fortis, Gurgaon. And that's me. I'll be introducing the faculty and talking on imaging and diabetic retinopathy. And we have Dr. Anisha, who is consultant at Delhi Retina Center. She is with me. I'll be introduced. We have a guest speaker as well. So I'll be introducing the guest speaker. So we will have your talk in between, and I'll shortly be introducing you. So I'll start my talk on protocol-based management, introduction to the DME. So DME needs, why should edema occur in the macula? That's because most of the fluid gets accumulated because of most dependent position of the macula. It has got space for expansile, so it causes accumulation of edema in the extracellular space. And this was initially classified in multiple ways, like a focal maculopathy, diffuse maculopathy, ischemic maculopathy, and clinically significant macular edema. All of us know what CSME means. We have learned during our undergraduation, post-graduation, the definition of CSME, and I will not dwell much upon it. But what has happened now with the drca.net is differentiation between so can we have the lights a little dimmed if possible? Can be divided into a center involving DME and a non-center involving DME. It's important to know this because the treatment for DME is now based upon whether it's involving the center or whether you have an extrafoveal edema, because the center involving DME has to be treated with pharmacological modulators, predominantly anti-VEGF, and an extrafoveal edema by the ETDRS definition of doing a focal laser can still be done. Now when you have a center involving diabetic macular edema, you can divide it based upon the OST pattern into these 9 quadrants. The central 1 millimeter is most important, which is the central involving diabetic macular edema, and you have the parafoveal area and the peripheral foveal area, which you can again grade it into superior and inferior nasal and temporal. Now, the pathogenesis of the diabetic retinopathy, as far as the basics go, you have occlusion of the vessels, you have leakage because of formation of microaneurysms, because of loss of the endothelial pericyte relationship of 1:1, which leads to aneurysm formation, which leads to leakage and accumulation of fluid in the extracellular spaces. There is lipid infiltration and formation of hard exudates. And the occlusion leads to production predominantly of vascular endothelial growth factor, and that is the basis behind for us to use anti-VEGFs. Now there are numerous biomarkers which are involved in diabetic macular edema, and there is a definitive pathway, and the main thing being a hyperglycemia that leads to various interventions, which is because of inflammation. So we have production of VEGF, which is extrafoveal, or in our cases of PDR, when there is neovascularization, you can treat it with lasers. Then you can use steroids because inflammatory modulators are involved and steroids take care of them. And then you have use of anti-VEGF. We'll be focusing mostly on this, but there are other molecules which are experimental, which are being used, but we will not dwell much upon the other molecules, other pathways. Now, vascular effect of advanced glycation end products is an important concept. The enhanced generation of advanced glycation end products is linked to the macrovascular or microvascular complications, and age activates specific receptors, that is the RAGE receptors, which trigger oxidative stress, inflammation, and apoptosis. Now, it's known that age modifies intracellular proteins, it regulates gene transcription, and they are involved in various biochemical effects which are manifested in diabetic macular edema and diabetic retinopathy. Now that's about a nutshell of what pathogenesis of, one can keep talking about pathogenesis for the whole 1 hour. So we will go on to something which is more practical for you, the imaging in diabetic retinopathy. So this I'll cover under colored fundus photography, stereo fundus photography, fluorescent angiography, optical coherence tomography, a bit about OCT angio, fundus autofluorescence, and we will just mention about microperimetry, electrophysiology, and OCT angiography. Now, FFA has been the age-old way of documenting fluorescent angiography and documenting most of the retinal disorders. So this is a patient who is type 2 diabetic, 6/6 vision with a dot retinal hemorrhage, but you can beautifully see the vascular arcade being preserved in the macular area, and there is a single microaneurysm but needs no intervention. Another patient where you can find the foveal avascular zone increased, there is a breakage of the capillary network. The patient's visual acuity is 6/12 because this is a situation of an ischemic macula. Another patient with an enlarged FAZ. So all these things can be documented by fluorescent angiography, and an ischemia cannot be documented by OCT angio unless and until you document a thinning in the retina, which will probably be extremely late. Then it helps us in identifying, when we were not using anti-VEGF, for identifying the leaking microaneurysms, which we were able to laser. So this is a slide way back, which was done in 2005. When we lasered these areas of leakage, and they did pretty well. But for the same situations now, we will be using anti-VEGFs. So angiography also helps us in identifying NVE, which would otherwise be missed, and I think Anisha would be covering this and would help us also to identify the capillary non-perfusion areas, which we'll be discussing again. Now, autofluorescence, as such, we don't use much in diabetic retinopathy, but autofluorescence is important, and I'll just show you a few pictures. This is a normal patient, or this is how autofluorescence will look like. And this is a multimodal imaging of a patient with a color photography. Then you have the microperimetry, the autofluorescence, and an OCT. So there is more stress now on a multimodal imaging, because each one of them gives us a different perspective of diabetic macular edema and diabetic retinopathy. So the take-home message for the role of FFA in diabetic retinopathy, it confirms the presence and extent of macular ischemia, identifies the leaking microaneurysms, confirms all area of doubtful NVE in NVD, and demonstrates the area of capillary non-perfusion, and it should be done in diabetics when seen for the first time, when the patients can subsequently be followed up on OCT angiography. Now we have an option of a wide field angio. Like in this patient, you can see there are large areas of capillary non-perfusion in the periphery, which would otherwise be missed if you do a routine fluorescent angiography. So this patient you can see beautifully these areas of NVE. There's a large area of capillary non-perfusion, and this patient has a macular edema on the OCT, but patient needs a laser photocoagulation of the retinal periphery, and the edema subsides after doing the laser photocoagulation, and no treatment with anti-VEGFs is required when the patient had already received anti-VEGFs in the past. So the take-home message is wide field angio helps us in identifying peripheral ischemia and helps us in sometimes treating macular edema, which has already been treated with various pharmacological modulators, and one may have missed a peripheral ischemia in these cases. OCT, this OCT actually reflects, you can on this picture on OCT you can have there are 6 layers on of the inner retina and 6 layers of the outer retina on an OCT. And these layers can all be picked up, and they help us in identifying the various things which go on individually in different layers. And I'll just dwell upon the inner retina and outer retina. There are 5 patterns of OCT described, and each pattern has a significance because the treatment can be based upon the pattern which we have. Like you have a spongy edema, which is preferably treated with anti-VEGFs combined with laser photocoagulation. Then you have cystoid spaces, which if patient is pseudophakic, we prefer to use steroids, and Dr. Vishali and Professor Atul will be covering this. Then you have full thickness cystoid spaces, which might need an intervention with intravitreal Ozurdex. And whenever you have a patient who have a subfoveal serous retinal detachment, you must always consider a patient to be having a renal problem, should be investigated, and we'll show you cases where a pure dialysis actually helps the patient. Then you have a taut posterior highlight, and these patients should actually be subjected to a via surgery with and rather than pumping them with pharmacological modulators. And so the vitreoretinal interface can now be assessed pretty well on an OCT. So if you have a patient here, you can see the vitreomacular traction being demonstrated very well, and this obviously causing the macular edema would need a surgical intervention. And then we talk about the inner retinal problem, which is now being labeled as a disorganization of retinal inner layers, which is basically because you're not able to differentiate between the ganglion cell layer, the inner plexiform layer, the inner nuclear layer, and the outer plexiform layer. So this is a paper which was published in 2014, which beautifully shows that all the layers can be identified, but in this particular picture, there is a gap which is present here. So this is the drill which can actually be measured. Now here you have a large cyst, but you're able to identify all the layers, which means that the drill is not present here. So a patient who has a drill is likely to have a poorer visual acuity, particularly when you follow up, and it's been shown in this particular paper that if you follow up these patients, you can predict a drop of 1 line of vision at the end of 8 months, and if the drill is increasing, you can prognosticate the visual drop in these patients. So this has also been linked with the amount of capillary non-perfusion has been found in connection with drill when it was correlated with OCT angio, where they could show that enlarging areas of OCT angio corroborated with the presence of drill. And this is a beautiful paper which showed that with a 300 micron increase in drill during a 4-month period, the visual acuity after 8 months dropped by 1 line. And this is the OCT angio which showed correspondence of drill with the integrity of the outer retinal layers. And then we look at, inner retinal layers, and then we look at the outer retinal layers, and this is basically a cartoon which just magnifies the layers we are looking at. We're basically looking at the external limiting membrane, the outer segments, the ellipsoid zone, and these are, so if you have a patient like this where you're able to identify the ellipsoid zone and the external limiting membrane, patient is treated with anti-VEGFs post one injection, second and third injection, and now you're able to identify the different layers of the outer retina extremely well. There are situations where you may not be able to identify these layers, but do not worry. You have to inject an anti-VEGF in these cases, and maybe subsequently after 1 injection you will be able to identify these layers much better, and then you can prognosticate if the patient is going to do well or not, like in this patient who had been given 4 injections, and this is what the picture initially was, and this is the picture eventually the patient did well. So the take-home message, I've already explained to you that FFA basically for macular ischemia, identifying the areas of leakage, NV and NVD, And OCT tells us about the vitreoretinal interface, the inner retina about the drill, and the outer retina ISOS junction. Thank you. So I will next invite Dr. Neeraj to be giving his talk on clinical trials. I'll request Anisha. So what we'll be doing is we have two things. So Anisha will be covering up the case discussion, so you can come up and while Neeraj loads this thing, you can ask the panel.
I think we start the presentation or? Good morning, everybody. My topic for presentation is clinical trials in diabetic macular edema and their practical relevance in our Indian scenario. There have been various trials conducted earlier which emphasize the need for metabolic control of diabetes to control the diabetic macular edema, like DCCT, diabetes complication control complication trial, UK PDS field trial, and they all emphasize upon the systemic control. And we have been doing laser for a long time, grid laser, to prevent the visual loss in diabetic macular edema patients. But there was an unmet need where we were not talking about the visual recovery in such patients. So there have been various clinical trials in form of giving intraocular injection of steroids, anti-VEGF drugs, and maybe surgery also to improve the visual outcome in diabetic macular edema or diabetic retinopathy patients. So I'll be talking briefly upon some of the important clinical trials which have increased our understanding of diabetic macular edema management. READ study was ranibizumab for edema of the macula in diabetes, and there were 3 arms in this study. One was where the grid laser was done alone, and other was where the injection ranibizumab was given alone, and where the laser was combined with ranibizumab. And if you see, in the ranibizumab group alone, where the only injection was given, there was more improvement in visual acuity by plus 7.24 letters at 12 months, and more than 3-line improvement in 22% of the patients, instead where the combined treatment was given. So, another interesting reading was adding laser to the ranibizumab treatment resulted in less number of ranibizumab injection, which was also an important finding, because giving less number of injection is going to also decrease the cost for the patient. Another trial, resolve trial, was done for 151 patients. One patient, there was a sham group, and other was ranibizumab group where the 0.3 milligram was given, and another group 0.5 milligram was given, and the dose was increased by double, 0.3 to 0.6 milligram, 1 milligram, if the patient didn't respond to the treatment. And rescue laser was done even if the patient was responding to the increased dosage also. If you see here, all the patients where the ranibizumab was given, all patients showed improvement in vision by a gain of 9.6 letters on an average. And the central retinal thickness, if you compare with the sham treatment and laser treatment, it was significantly improved and was consistently there for the last 12 months' time. So in resolve study at 12 months, ranibizumab treated patients gained to 10.3 letters in BCVA with a mean number of injections versus a loss of 1.4 letters in the sham group. And dose doubling was also frequent in sham arm and the patients who were getting laser treatment. And also it gave us insight about the safety of these anti-VEGF drugs. It was seen that there was no non-ocular serious adverse events or no increased risk of cardiovascular or cerebrovascular accident in ranibizumab group versus control group, which was one important finding. Even practically also when you're treating patients, you need to convince them like you're not going to harm them. And ranibizumab monotherapy, whether combined with laser or laser monotherapy. Monotherapy was much better than doing combined treatment or laser treatment only. And improvement of more than 10 letters was seen in patients when they were compared with laser monotherapy. Another important study to see the role of bevacizumab, off-label use of bevacizumab in diabetic macular edema, it showed 8 letters of increase in visual acuity over 1 year period time. DRCR network, Diabetic Retinopathy Clinical Research Network, also gave us different trials were conducted, and I'll be touching upon few clinical trials of them. It showed the role of ranibizumab versus deferring laser for 6 months better. And it showed that deferring laser treatment was much better than giving only ranibizumab treatment. Here you see that this green line is for the ranibizumab group, which was maintaining a high visual acuity, and also the combined treatment is little less than that. And all this transluminone and prompt laser, initial recovery, visual recovery was there, but over a period of 2 years, you can see that the vision was going down. And also the number of injections, you can see per study, as the years increased, the number of injections also went down. And majority of the patients, they were maintaining good vision, 9.8 letters, 7.2 letters in ranibizumab alone and prompt laser group. Another important protocol to see what was the role of laser, ranibizumab and steroid for diabetic macular edema. And it showed in all 4 groups, the intravitreal ranibizumab with prompt or deferred laser had superior visual acuity and OCT outcomes compared with focal or grid treatment alone. And more than 50% of the eyes had substantial improvement in more than 10 letters, while 30% gained more than 15 letters. And in pseudophakic eyes, clear-cut role of intravitreal steroid was given by this study, because other patients, there was development of cataract leading to further loss of vision, necessitating another surgery. So these were some of the confounding factors in this study. Retain study was done with an aim to see whether you can decrease the number of visits what the patient can make to a retina specialist for giving injections. So in this, there were 3 groups. In group 1, treat and extend ranibizumab 0.5 milligram plus laser was given on, and another group had monotherapy, and third group had PRN-based ranibizumab. And primary endpoint was seen at 12 months, and study completed at 24 months. What was happening in treat and extend group? You give 3 loading doses, and then you see if the vision is stable, OCT finding good, then you give a gap of 1 month, then you give injection. If again the patient is maintaining stability another 2 visits, don't give any injection. Then you give injection at 2 months interval. So basically you are decreasing the number of injections for the patient and making him more compliant. And you can see all 3 groups are maintaining good visual acuity, almost at par. And also in treat and experiment showed over 40% reduction in monitoring visit, which was comparable to the PRN group. So treat and extend regime was attempted to minimize the clinical visit, number of injection, and ancillary testing. Da Vinci study was done to see the role of aflibercept in various doses, 0.5 milligram every 4 weeks, 2 milligram every 4 weeks, 2 milligram every 8 weeks, to see, because this molecule has been act like a VEGF trap, so the duration of activity remains a little longer than the ranibizumab. And it was seen like in all the patient category where the aflibercept was given, the visual acuity improved and the OCT went down. Another important protocol T, where the head-to-head trial was done for aflibercept, bevacizumab and ranibizumab for diabetic macular edema. So there were 660 patients, 2 milligram intravitreal aflibercept, 1.25 milligram of bevacizumab and 0.3 milligram of intravitreal ranibizumab. You can see the dose is half of what has been used for CNVM. And you can see the overall improvement in visual acuity was better in aflibercept group in comparison to the bevacizumab and ranibizumab, and also in terms of macular thickness. And also no adverse events were seen as shown in earlier like RESTORE study also for the ranibizumab, like no adverse events were seen. So factors limiting the generalizability of protocol T was, it was partial masking was there because the investigators were knowing what treatment they are giving to the patient. Though the technicians were not knowing, but it was partial masking, and also the dose of half of what we routinely use for treatment of AMD was given. So that was one of the confounding factors in this study. So what current evidence do we have on diabetic macular edema and what various guidelines we are managing? Actually, we are mostly following the protocol. If diabetic macular edema is there, if no central involvement, then treat according to ETDR with laser. If central involvement, no vision loss, then just observe the patient. If it is not vision threatening. If it is vision threatening and vision loss is there, then you give monotherapy with aflibercept or ranibizumab. And patients with progressive worsening visual acuity over 3 consecutive visits in presence of active DME, when the cause of vision loss has been ruled out in terms of macular edema or vitreomacular traction, then you should consider the patient is not responding to your anti-VEGF therapy. You need to shift to another injection, maybe another anti-VEGF or steroid injection. And anti-VEGF should be, we are giving a monthly doses, 3 months loading doses, and then depending on PRN basis. And if the vision is stable, then you can stop giving injections and monitor the patient. And decision to treatment continuation, interruption or reinitiation is based on the 2 factors, vision and second is OCT. First is vision actually. OCT should be done to monitor DME stability and for confirming whether loss is due to diabetic macular edema or not. And role of angiography should not be like subject, because it is also important to see sometimes macular ischemia is there and you are giving injections and it is not working. And patients with progressive worsening of vision who are non-responder, you should consider alternate therapies, alternate anti-VEGF, maybe from ranibizumab to bevacizumab or bevacizumab to aflibercept, or steroids, especially if the patient is pseudophakic. Thank you for your time.
Thanks, Neeraj. So what we'll do is, can I ask Dr. Vaishali to come up on the, please. We will have a talk by Dr. Atul, Dr. Atul Kumar on anti-VEGFs in DME and PDR, and then we'll have the talk of Dr. Vaishali, which will cover lasers and steroids, and then we'll have a set of questions which will cover all these 3 aspects together so that we can interact. And I would request all of you, if you wish to ask questions to the panel, it can be simultaneously. Then I'll request Professor Atul to start his talk.
Thank you, Ajay, and a warm welcome to all of you at the AIOS conference, which is in the beautiful big city of, historical city of, many of our cities are historical and Jaipur is one of them. So it's nice to come. I'm from Delhi, so yeah, I just came in today, and always a pleasure to visit Jaipur like many other cities. So I'll talk about certain because I have 9 minutes, I'll quickly talk about certain tips and practical points which are important for using anti-VEGFs in both for diabetic macular edema as well as for proliferative diabetic retinopathy. Now, this important thing to understand is anti-VEGFs have come here to stay, and probably they've assumed a very important role in the management of DME, either as a first choice, usually with center involving diabetic macular edema, or as adjuvant to laser, which had been the gold standard and still is for many retinopathies. But for DME, center involving DME, now anti-VEGF is the first line of treatment. Now, most of the DME trials, and I would request you also to have the OCT facility available to you even if you don't have the machine. A high resolution OCT is important to pick up the diabetic macular edema, and you can see here that the center involving DME which is visible. Now, this is a swept source device which shows up the vitreoretinal interface as well as the choroidal thickness at the same time, which we use at RP center. So the cystic spaces come out very clearly on the various 12 clock hours scanning. And once you have a central involving edema, you can also decide that you need an anti-VEGF. From OCT, I'll come to fluorescein angiography. Fluorescein angiography has a definite role in diabetic retinopathy. There was a time when they said PDR probably not required because we just had the 50-degree camera. But with the advent, as Ajay just told you, there's a wide field angiographic devices are coming in, and probably will have more cheaper, and I've heard that Heidelberg is coming out with a wide field device also. So we'll have more competition, and I'm sure the costs will come down, because biggest problem in ophthalmology is the cost factor which is there. So this is a montage taken on a Heidelberg HRA, but this shows the field is much less than 100 degrees, which is required. DRCR.net, which is a multi-centric study trials which are going on with various centers in the US, say that to call it a wide field, it has to be more than 100 degrees. So this is giving a field of about 90 degrees. So that's a little problem, because though it can see the retina, but it cannot see the periphery of the retina. Now, for DME also, it's very important to see the periphery. Why do we say that? Because they say Paul Tornambe has said that DME is fundamentally a peripheral retinal disease, which is saying a bit too much, but manifests secondly in the macula. In his series, he showed several cases of refractory DME, or what you can say recalcitrant DME, which resolved after laser to the far retinal periphery. And what they say is that to prevent the laser-induced visual loss, the night vision, driving vision, the glare, it's better to give laser in the far periphery rather than give it near the equator. So it's better to do a wide field angiography, which gives you a panoramic view, and you can pick up the ischemic areas in the periphery. And then, as you see here, the ischemic areas are picked up. There's neovascularization over here, which is the standard areas which we treat, but it's also already heavily lasered. What has not been lasered, which is seen on the ultra wide field device, which is a 200 degree, shows the peripheral ischemic area which needs to be treated. You often see cases like this at our center, and we feel that we often treat them completely, and we find the results are not too bad. Of course, we are doing some research work on that. We'll have a published data very soon. So this kind of a patient is another patient who's, you can see the ischemic areas which are there in the periphery. Often these ischemic areas, by the time if you do a 50 degree standard, use a montage image, though I wouldn't say wide field has to be there, but a montage image can also pick it up. But sometimes when the dye flows out very quickly, you may not see the ischemic area so well defined as you can see in the wide field device. And people have calculated the ischemic index, and they've said that this patient is prone to go into PDR. Now, refractory DME is something which I'd like to tell you in this short talk, that it can be something which it's difficult to get a proper definition. So I personally felt that based on the drcr.net protocol T and IE and protocol S, it's basically that it's less than 10% change in the OCT thickness in microns, and or less than 1 line improvement gain in visual acuity after about 4 loading doses, 4 to 6 dosing doses. The protocol T is taken 6 loading doses, but the protocol I took 6 loading doses, but the protocol T took 4 loading doses. So we have 4 injections of anti-VEGF monthly, and you find the thickness is less than 10% reduced, and you find the visual acuity is less than 1 line improvement, then probably he's a recalcitrant or refractory DME. Study the periphery, study the blood sugar control, also get his renal functions, and also sometimes it's required that he may have certain other factors which are important to systemic hypertension and all. So this is just a protocol T which just now we heard Neeraj tell you very nicely, and this basically showed that the first year of treatment there was very aggressive anti-VEGF treatment, and finally visual acuity improved at the end of 2 years, over 2 years in all the 3 groups, whether it was Avastin, Eylea or Lucentis, the classical clinical dose. After this, as the first year ended, the second year and the third year required very less injections. So in DME it is not like wet AMD or neovascular AMD where you have to dry the retina. You have to get a stable vision. Don't get the last cyst out. Because DME, the results are not very, you don't get a wow factor, you don't get a very marked improvement. You just have to make the patient visual acuity stable. Once the vision is stable and the OCT even shows a little fluid, you may continue without injections, because too many injections may actually cause macular atrophy. Wet AMD you need to dry, because if they don't get dry, if there is subretinal fluid, they may have a subretinal bleed. So wet AMD is a different thing. There you have to be very, very, very aggressive. So efficacy of all the drugs was high. Only one patient switched anti-VEGFs after the first year. And this is again a swept source OCT which we use, shows a pre-anti-VEGF, and after 3 monthly injections he had come down quite a bit, and this swept source OCT device has a OCT-A also. It's a multimodal imaging machine, which is preferable to have multimodal, because you can do you can actually study the patient in great detail. You can study the cystic edema, and this is basically the flow of RBCs, and you can see in between you have the cystic edema, the dark areas, and the resolution of the edema. And this is the study which showed that the protocol T, that the ranibizumab and Eylea are literally nearly the same. They're nearly the same. If you can take lesser vision, less than 20/40, or better than 20/50, they had 2 groups, the better vision group and the worse vision group. But they showed nearly same results for ranibizumab and Eylea. So actually also practically we feel they are nearly about the same. So I won't go into this. This is the next protocol which is important from this talk point of view, is the protocol S, which has recently come. There they say ranibizumab or Lucentis is non-inferior to PRP. So it's actually a PRP versus anti-VEGF. And the PRP patients can sometimes get an anti-VEGF. So it's Lucentis versus anti-VEGF. The biggest advantage of the study was that the vision did improve in the anti-VEGF group. The field loss was much less, which was seen in the laser group. As you can imagine, the laser causes the field loss, it causes dark vision, dark adaptation issues, it has contrast sensitivity issues, it has accommodation problems. So I'm not against laser. I myself do a lot of laser, but I'm just saying that when you've associated DME, then it may be better to also give the anti-VEGF, but you have to go, these are basically guidelines. You don't have to follow them, because these studies are often company driven. They are not like NIH studies which are sponsored by the National Institute of Health, Bethesda, Maryland, where they lay down guidelines. So you can take out points from this, that if they DME with PDR, probably to give an anti-VEGF first, and then you can do the laser. Now this is the OCTA on the swept source OCT. It's a SSOCTA. Swept source OCT is a 55-year-old male who has, we get a lot of as you all must be getting chronic kidney disease. Whole lot of them keep coming, and post he had PDR both eyes. He had OD, he was operated elsewhere, he had 1/60, disc was extremely pale. Left eye he had 6/18, which is the eyes I'm showing you. And he had NVD with ischemia. Now these are the kind of patients who's got CKD, fluorescein would be contraindicated. That's where the OCT comes in. One of the indications for getting an OCTA. So I'm not saying you have to have the OCT, but the facility is going to be soon be required, just like Whitefield. This is talking a lot of expensive equipment, but this is going to be, it'll be practical to do treatment without these new devices. So NVD with ischemia. Now we could see the retina getting a little pale. The FAS, so we did this thing, and you can see the neovascularization all around the disc. This is at the region of the disc. This is at the vitreous. So you can see the neovascularization, the OCTA. This is on the OCT showing the new vessels. The best thing about the OCTA is it calculates the foveal avascular zone. We found the vision was, if you see, 618 in a case of NVD with a lot of retinal ischemia. But his FAS was 867. But he had ischemia over here. So probably he requires laser, and he just requires a little bit of gentle laser as a focal laser, and then go around and do a little bit more laser in the periphery. But for this central edema, I don't think we'll give an anti-VEGF, because he hardly has an edema over there. So we just do a little laser. You can see the pale disc is kind of caught blood in under the hyaloid. Instead of pale retina, thin vessels, typical of a CKD patient. Now this is a modified protocol S. This is my last slide, which I was telling you the protocol S can be modified, that you got a PDR eye, this and this. This is a color picture. This is the Whitefield angiography which we've done. You got PDR with DME. This is the DME on the swept source. And so we give the anti-VEGF 3, and we did the scatter laser. This is the modification. As they say, because the biggest thing in the protocol S is the biggest drawback. If you can say advantage is the drawback of the study. If the patient does not come to you back, you're going to have very severe visual loss in these patients, because they'll get more florid and they'll go into TRD or vitreous hemorrhage, and then you'll have surgery on your hands. Anyway, many of these patients require surgery later on when they get detachment. So when we did the scatter laser, we did the Pascal laser, we did it as a targeted laser. We don't do laser as a PRP. We do areas which are showing ischemia, we just put the laser. So more into the periphery you can do, and the edema has gone down because of ranibizumab probably, and the ischemia has been taken care of by scatters. It's a little modified. Thank you so much. We are also celebrating our Golden Jubilee years. Just thought I'll mention it to you.
Thank you, Professor Atul. You can ask him questions after Dr. Vishali's talk. So we have some situations for him as well as Dr. Vishali. And I would ask Dr. Nachiketa Acharya, who is a keynote speaker, to please join us on the dais, sir. I'll be giving an introduction after Dr. Vishali's talk. Please join us.
A very good afternoon, and thank you, Ajay, for having me here. Ajay has asked me to speak on lasers in the management of diabetic retinopathy and steroids in particular for DME. Dr. Atul has already spoken about proliferative diabetic retinopathy. In our scenarios, when we see proliferative diabetic retinopathy, we still have a tendency to do PRP. We judicially have to combine anti-VEGF with PRP, because there is no way we can go on to anti-VEGF monotherapy for PRP in a country like ours. So that part has already been taken care of. So question comes, is lasers for PTR? Do we need the lasers? That's a question we have been. Now, to my mind, when we look at the PTR, it is the end result. End result of what? The cause is there are lots of areas, my pointer is not working. There are lots of areas of capillary non-perfusion that you see there. Those areas of CNP are producing VEGF. VEGF is producing angiogenesis, as you see here, the new vessels. When we are giving anti-VEGF, what are we treating? We are treating the effect of this thing, and the effect is NVDRNVE. But what is the cause? The cause is here. The cause is there are a whole lot of areas of CNP which are producing new vascularization. And as Dr. Atul says, trials are no trials. What the logic says? The logic says you first take care of these NVDs because you don't want them to bleed. You know your laser is going to take about 6 weeks or more to start effective, and these vessels are going to bleed in the meantime. You take care of them. You don't want your diabetic macular edema to worsen while you are doing PRP. You take care of that by giving the injection, and then for the long term, you do PRP because our patients are not going to come back for 2 years to receive monthly injections. Everybody, I'm sure, in this hall knows how to do PRP, so I'm not going to do. There are different types of lasers for which we have been using. This is the conventional, and now we have the Pascal. Pascal is basically more of a convenience rather than the efficacy, but it looks beautiful. You have different pattern. There is no pain to the patient, and you can do it quickly. So you can choose a pattern, and you can choose the area, and you can do the laser whichever way you want. Now we come to the more, other than the Pascals, what are the new lasers? One of the new lasers that we have is the Navilas. So what is exactly the Navilas? I won't bore you with all the technical details. So we come to the Navilas. It is especially important now when we are doing the diabetic macular edema lasers. Because many of the times we do say anti-VEGF, and personally given a choice, I do give anti-VEGF to all my patients as first line. But sometimes when your edema is regressed, you are seeing microaneurysms, or in a treatment-naive patient, you are just seeing some focal leaking microaneurysms, and you know from your past experience as well as ETDR experience that if I do laser to these microaneurysms, I would be good to go. I may not have to inject them. So you want to do lasers. So which is the safest laser to do? That is the question. So we come to one of these newer lasers, which is the Navilas. As I said, what is our reluctance in doing laser in this era? Why are we so scared of thermal lasers? One, we have seen over the time that the patients who just undergo lasers, and in our country we have seen patients undergoing laser without even getting a good metabolic control. So you do laser, all your hard exudates come in the center, they sit into the fovea, and we say lasers are bad. Well, it's a multifactorial disease which has multiple factors. So why do we not like thermal lasers? And why do we have poor response? One is that when we are seeing macular edema, as I said, macular edema is the effect, and the cause is anti-VEGF, cause is VEGF, and that VEGF is coming from the periphery. So what do we do about it? Now this is an example. You have macular edema, you have cercinate, and you have this whole lot of areas in the periphery which are not treated. What you do Optos wide angle, it looks very good, but there is another situation where you have macular edema, and you have already seen by Dr. Atul that you do have the areas which are producing those VEGF. What we are doing is we are treating this macular edema with anti-VEGF, more anti-VEGF, but that anti-VEGF is coming from these areas, so why not treat them with targeted laser photocoagulation, not killing the entire visual field, but at least targeting these areas of capillary non-perfusion that we assume are producing VEGF. This is an example. You see that, you see a whole lot of capillary ischemia in the periphery. So ultra-wide field would be useful if you want to do the laser-guided treatment along with the anti-VEGF. And we come back to what are the limitations of thermal laser. One, we don't have any clear-cut guidance. It is your way of doing versus my way of doing. And sometimes sitting there, you look at it and it's kind of your signature on the retina. You can make out. Some people have a particular signature. You say, oh, this laser was done by so-and-so. There is no protection of vital structure, and that is very important for our young colleagues. Sometimes they get confused. There is no eye tracking, no digital documentation, and no consistency in application. So what is the answer? The answer is, so far, I have tried to say that lasers are a part of the treatment. So we do need lasers, so why not shift to something which is safer? And this is an example. If inadvertently you make a mistake and put a burn in the fovea, this is how a normal mosaic of adaptive optic looks like, rods and cones, and this is this patient with the laser burn. You see, forget the diabetic macular edema, we have killed all the cones in the fovea. So this is a catastrophe that we all are very scared of. We want to avoid. So what do we do for that? We have a Navilas, which is actually a navigated laser. What does the navigation mean? Navigation means you have the patient on the same machine, you acquire the fundus photograph, you do the OCT, not angio, sorry, you can do the OCT and the fluorescein angiography. For example, this is the patient. You identify the microaneurysms, these small yellow dots. These are the areas I want to do laser. And then this huge dot is the area I want no laser. I want to protect it. So the laser is not going to treat this area at all. So it's more kind of precise and driven. Some of us do like to treat OCTs and the maps, though I don't personally know why. So you can actually treat it based on the OCT. And this is the left eye of the same patient. You have a diffuse leakage. You want to do kind of modified grid. And if you happen to do PRPs and you want to protect your disc as well, you can do that also. So after that, you are not shooting anything. Actually, machine is doing it. When it keeps on doing, it keeps on telling you the areas which are lasered, which are not. You keep on doing it. There is eye tracking. Even if the patient is moving the eye, it will come back to the same position. This is the post laser. You can see the microaneurysms going. So some of these newer lasers we do have to overcome the limitations. We do have micropulse. Ajay has a lot of experience with it. And just in the prior session, we were discussing that microperimetry performed after micropulse shows that it doesn't do damage to the retina. We do have fancy things like nanosecond from the micro and the photo rejuvenation. So this finishes with my laser, which just says that we need to find the laser options, and this is the era of the customized therapy. So we have to look at the patient and use all our approaches to say what is best for it. The second part of my talk is where are we using the steroids or the implant. In that case, my cases belong to the implant. I have no financial interest to disclose in diabetic macular edema. So currently the indications for me are these 5 as I have listed. Let's go over one by one. This is the first patient where you see an exuberant subfoveal fluid, and you know there is more of an inflammatory component rather than pure VEGF, and more important than you want an early rehabilitation. You want your photoreceptors to go back so that they start breathing again. This is the case. I would combine it with the steroids, or I would give steroid as a first line, and we can see the outcome. And the second one is recalcitrant diabetic macular edema, like if you have been injecting and you are not able to take care of diabetic macular edema, so probably there are inflammatory molecules which are other than VEGF in play, so try something different. This is after 3 injections of bevacizumab, and this is intervention with steroids. The edema comes down, and of course it comes back again, but then you got to take your call. Persistent CSME after vitrectomy you have done. So this is the kind of the tractional component. This is post-operative, but the edema persists. And this kind of cystoid edema responds very well to the treatment, for example, this one. Surgical intervention, we have reported this now that if you do the surgery alone, it takes about 2 to 3 months for the visual rehabilitation. But if you remove the traction and give an implant intraoperatively for the macular edema, the rehabilitation is much faster. For example, this is the patient who underwent surgery. You can see 3 months later also he has few cystoid spaces because he just underwent surgery, no implant. But when we combine the implant with this surgery, this is the pre-op. You can see the taut hyaloid with the cystoid spaces. So you remove the hyaloid, you remove the internal limiting membrane and put the implant. This is pre-op. This is 3 days. This is 1 week, but within 2 weeks you can get a good anatomic and an early rehabilitation. And my last slide is cataract. We all know cataract causes worsening of diabetic maculopathy. And this is the preoperative patient. He had significant cataract and you can see some laser marks. He had received anti-VEGF. So intraoperatively, we have published this in ophthalmology now. He received Ozurdex along with phaco and IOL, and you can see post-operative day 7 because cataract is going to increase the inflammation, and it's not VEGF it's going to increase. It is the IL-6 which it is primarily and prostaglandins. So you got to treat it with this. So to conclude, it's important to look at the peripheral retina and treat it even for diabetic macular edema. We need a safer laser options. Navilas is one of them, micropulse and several others in the pipeline. Retinal rejuvenation therapy, I don't have any personal experience, but something which looks promising. And steroids in the select solution, because as I always say, the etiology is multifactorial, so the treatment also has to be multifactorial. Thank you.
Thanks, Dr. Vishali. Anisha, can you just, we'll quickly go through 2-3 questions.
Good afternoon. I think we're a little short on time. This is a case that Dr. Ajay has already shown, just to show the importance of doing an angiography in an otherwise quiet looking eye. The FA shows so many NVEs. I want to ask the House as well as the speakers if there are any precautions that need to be taken before a routine angiography. We normally get a KFT done, BP. Is there a role of a pre-injection dexamethasone and a standby anesthetic if required?
We usually get the sugars, the kidney functions and the blood pressure definitely. If the patient, often they are hypertensive, uncontrolled, and they often are diabetic sometimes. So then we get the cardiology and the endocrinology consultants to also have a look. And once they get we get the clearance, only then we go ahead and give the anti-VEGF. Even if it means usually come back within a week with the clearances.
So that is in AIMS. Manish, what about you?
Well, practically we just go by the history of any kidney issue with the patient. If the patient says they have a creatinine levels which are high or something, we don't specifically get it done. He comes to a consulting, and if we need an FA, we just take a consent and
so
do it.
Do you have a backup anesthetist?
Yes. I mean, he's there in the hospital, but we don't necessarily have him that place itself.
Thanks. We can go to the next question because short of time, so I think
I want to discuss a bit about angiosity. What is the role of angiosity in diabetics in today's scenario? As in this patient, we had a patient of PDR, very nicely visible NVD on angiosity corresponding to the FA. On the macular scan, the FA is even better visible than the angiography at all levels. So what is the role and what is the future that we are looking into?
Professor Atul and Vishnu.
Yeah, now see, OCTA is going to be very valid in the treatment as time goes on. It's going to be a very valid investigation. And there are patients, I showed you one patient who had chronic kidney disease and where angiography was contraindicated, and they've had renal transplant. So there, of course, it's very mandatory to do a OCTA. But otherwise also to check the perfusion status, it's very useful. It won't give you leakage, but the perfusion status of the foveal avascular zone as well as surrounding areas, as well as seeing the amount of neovascularization occurring, and then seeing the regression. I think that all study will be very useful, and you can study the layers, different layers. So I think it will definitely have a role.
Will it change our treatment protocols?
It may change to some extent.
Dr. Vishali, what do you think?
It's very useful in differentiating collaterals from NVD. You don't have to do angiogram if you have a clinical confusion. We published it in Graphis Archives recently. Collaterals are seen in the retinal peripapillary layer, whereas NVD is in the vitreous phase because that's elevated. As Dr. Atul says, for macular ischemia, because normally the microaneurysms start leaking on angiography and they create so much of noise there that you can't see the intercapillary non-perfusion areas, which are very well delineated on OCT angio. It will be helping in prognostication, but for treatment I'm not very sure because it picks up only 30% of the microaneurysms because they are dead space. So anything which is dead, it doesn't show. So it doesn't show microaneurysms. But if I'm targeting microaneurysms, I would still go by the fluorescein.
Will it replace angiography?
It complements angiography, replacement not yet, because it doesn't show the periphery. It just shows the center.
I think it's a great indication for any diabetic coming to you with clear media and unexplained visual loss, where you can do an OCT for seeing how's the macula in terms of traction or cystoid, but then we sometimes have to do an angiography to see if there's FAZ issues. So that I think gets taken care of. You don't need a you don't need a fluorescein angiography to find out the visual. I mean, what is the reason for less vision in that patient?
Anisha will go to the next question. So you want to say something?
Just the FAS can be measured properly.
Yeah,
It can be really measured properly. When the fluorescein, when the dye leaks out, I mean, it's difficult to measure the FAS.
So in OCT angio, you have different depth-wise, you have different layers. So where do you measure FAS? People may ask you, do you
cross the superficial capillary layer or the deep capillary plexus?
So you have to measure it separately?
Separately you can do it. And you can see the deep capillary plexus sometimes more ischemic than the superficial capillary plexus. So it actually studies the retina in greater detail than the fluorescein.
Anisha, next.
Coming to center involving DME, what is the first drug of choice for all the speakers? This question is, what is the first drug of choice in a case of center involving DME, and what factors determine the choice?
So,
So anti-VEGF would be the first choice.
Manish?
Yeah, first choice is anti-VEGF.
Neeraj?
Anti-VEGF only.
Dr. Vishal?
Anti-VEGF unless the patient has recent pseudophakia.
Okay, Dr. Nachiketa, what?
We have recently switched over to ILE as the first choice.
Oh,
So
anti-VEGF.
that's anti-VEGF, yeah. But amongst the anti-VEGF, we prefer ILE.
Thank you. Next.
What treatment protocol for center involving DME do we all follow, and how many minimum number of injections should be given? Following that, should we follow a PRN regime, and what should be the ideal
I
follow-up?
think this
for a
has been
PRN?
covered. We go to the next one. Yeah.
What is the role of deferred laser, and especially peripheral laser, as ma'am had mentioned regarding the peripheral laser?
So
Are we doing a peripheral laser for non-resolving DMEs or recurring DMEs?
in other words, do we give 3 injections and then follow PRN and do laser at the same time, or we defer it? What the studies have shown that after 24 months or whenever we do a deferred laser.
The studies actually have not shown much of an improvement in treating the periphery targeting PRP. So I would first give only anti-VEGF.
For how long?
At least 3.
And after that?
After that, see if it is not responding to anti-VEGF, I would add some laser to the periphery. If it is still not responding, I would add steroids to it.
So you will not go on with more anti-VEGFs after the 3rd injection, you will add laser.
You know, many a times what happens is if the cycle is not breaking with 3, there is protocol S or whichever, I don't know, which has shown that whatever the vision the patient is going to have after 3 months is something which is likely to be at 3 months. So it makes sense to break the edema at 3 months at the earliest. So if your 3 injections are not working, I would rather do more aggressive by steroids, by TRP combining. Once after giving the steroids, my macular edema has come back to normal and it's a mild increase, I might follow it with anti-VEGF again.
Thanks. Anisha will go to the next one.
This is a 55-year-old male, diabetic for 15 years, who came to us with a vision of 618. As is visible, the patient had NPDR. On angiography, there was a lot of leakage. The sugar levels were very high. HbA1c was 12.3, and overall the control was very poor. We advised in OCT and counseled the patient for anti-VEGF. The patient came back 4 months later with a visual acuity of 6/9. We were surprised and but asked about what treatment he had undergone. Surprisingly, there was no treatment and he had only undergone a metabolic control. Only this had changed.
This is just to, this is not a question, but just to give the importance of metabolic control in all stages of diabetic retinopathy, whether it's DME or PDR or whatever, we must do a good metabolic control. You can go to the next.
This is another patient who had come to us, was admitted for dialysis, a diabetic, and that was the first time he came to us with a retinopathy. There was a lot of macular edema, the vision was low, and he underwent dialysis. 8 months later, the fovea was absolutely flat. Again, the importance of controlling the metabolic status.
Next, yeah.
This is a case, a diabetic lady, 60-year-old. She had undergone scatter laser 1 year back with us. She came back with a recent onset decrease in vision. There was macular edema, center involving. We started off with injections, anti-VEGF injections, multiple. She responded well, and then she had a CVA. So next we gave her an intravitreal Ozurdex. Again she responded. 6 months later the edema started to recur. Now since it had been 6 months, we gave her an anti-VEGF again, and this time we supplemented with a temporal focal laser. She responded, but again after this anti-VEGF she had another episode of stroke. The edema is back to its status. What are the management options for this
So
patient?
what is the,
Which
but
is
normally
now
they say after 3 months you can go back to your anti-VEGF, but 6 months later patient has had a second stroke. Obviously we'll never ever give an anti-VEGF again, but what does the
Repeat
practice-
Ozurdex.
Ozurdex.
She had shown a good response in the first place. If she's
Ma'am,
not a
And pray
responder.
that
Is
she's
there
not
a
a
role
responder.
of micropulse laser because
Yeah, of
Macropulse
course.
won't act with so much of edema. It has to come down before
after
we take.
Ozurdex?
After,
if we, because
once it comes down then.
otherwise we'll have to keep repeating Ozurdex every 6 months the way it's going to come
Sometimes
back
even
again.
after 3 months. It doesn't
3
really
months.
last 6
Yeah.
months.
So I think Anisha will go to the, we have a guest lecture by Dr. Nachiketa. He can come here while introduce him this. While he's getting his things, can I have this on for a second? This one? Dr. Nachi Acharya, who is very much part of India. He was trained in AIMS. He is well known as Dr. Nachi Acharya. He is a consultant of ophthalmologist at Sheffield at Royal Helmshire Hospital. He has a keen interest on medical retina, managing diabetic retinopathy. Will be talking to us on current management of refractive DME, and is also treating patients with ARMD, retinal vein occlusions, inherited retinal disorders. And it would be glad to know that not only, he's not segregating himself only as a retina specialist, he's also doing cataract surgery. Welcome, sir. You can switch over the.
Good afternoon, everyone, and thanks for inviting me for this lecture. I'm especially honored to share the podium with Dr. Thurkumar, who was my guide at RP Center. So it's a wonderful moment for me. And I'll be talking about refractive diabetic macular edema and how do we manage some of these difficult cases. We've already been talking about quite a bit about managing diabetic macular edema, and I'll be just be sharing my experience on how do we manage, because we have a slightly different setup compared to India over there in Sheffield. Here are my financial disclosures. Now we know that diabetes is an epidemic, and almost 1/3 of diabetic patients over long run will have diabetic macular edema, and that is the main cause for loss of vision in diabetes. And that's equally important than for us to know how do we manage these cases. The old classification of diabetic macular edema is probably not very relevant now, but we still need to know it as a baseline to know how the treatment regimens have evolved over the years since the ETDRS studies. Now, when I talk about diabetic macular edema, I talk about the patient in front of me. I don't talk about these big studies which give us excellent results, because end of the day, we have to customize the treatment according to our patients. We have to look into their visual needs, the associating health factors they are going through, and maybe in a setup like India, where you have to also look into the health economics, whether the patient can afford a certain treatment or not. We cannot just generalize all these treatments available to us for every patient. We have to think carefully what the patient can afford in front of us. And the treatments have evolved from lasers to anti-VEGF to steroids, and we are doing a recent big trial on micropulse laser as well for early macular edema. I would still say the first line of treatment is laser, especially if it is central, if it is extrafoveal, And grid laser is going more or less out of fashion now, because we've got excellent treatments with anti-VEGF treatment and better modalities to treat diffuse macular edema. So first line for extrafoveal macular edema would still be focal laser, especially in succinate cases like this. Or even in somebody like this, I would still prefer to do a focal laser in all these leaking microaneurysms which are away from the fovea. And quite often you'll find that being persistent with your treatment, eventually these maculas will start getting drying up, and you'll see an excellent result. We know that anti-VEGF has been the new treatment and is the key role in central involving diabetic macular edema. And the various studies have shown that ranibizumab and then bevacizumab, aflibercept or Eylea and triamcinolone, and then there are other studies which have given us some more insight into the role of these drugs in managing diabetic macular edema. And then we also have this role of steroids in diabetic macular edema, where we kind of reserve this treatment for patients who are not responding to anti-VEGF, or we are really desperate to find some solution for it. Now, my kind of approach to diabetic macular edema is that in chronic diabetic macular edema is that if the edema is extrafoveal, is not involving the center, you might just do a laser photocoagulation, or you just optimize the control and just observe them, and quite often you'll be fine with them. But when it starts affecting the center and the vision starts getting down, then you start considering either anti-VEGF and then combine them with some laser, and which will help. And quite often, if it's not helping, then you might maybe think about going on to to steroids. And for the chronic, it's the same kind of approach, but have to be a bit more aggressive. I've got a couple of cases to share, and that will help us in understanding how should we manage these difficult cases. Now, this lady came with a very poor vision, and you'll be surprised that even in UK we get cases like this, where we get bad macular edema, central involving, a lot of exudation in both eyes, with a very poor vision to start with, and an OCT looking like this, which is edematous. And it takes quite an effort for us to treat these patients, and you have to be very persistent with them, and you have to manage them, and you have to carefully design their treatment pathway. Now, this lady, over the last 6 years I've been treating, has initially had Avastin because Lucentis wasn't licensed for macular edema at that time. Then subsequently had 3 triamcinolone injections. She was getting injection of triamcinolone every 4 to 6 months. And that led to a cataract, and that led to a steroid-induced glaucoma. In between, when she was drying up a bit, we were again lasering them. We were kind of targeting each microaneurysm which we are seeing on the color photographs, and trying to control her. This led to her having cataract surgeries done, and followed by a tube surgery because her pressures were sky high. And then she went on to have more Lucentis when Lucentis was licensed. And eventually we ended up giving her Iluvian, which is a steroid implant. It's a longer acting steroid implant which lasts in the eye for about 2 to 3 years. And since then she has stabilized to a vision of 636 in the right and 618 to the left. And her picture looks pretty good now. And this has been like a sustained effort over the last 6 years. And she's been coming every 3 to 4 months, and we've been targeting the treatment. And it looks pretty dry, and she's been stable for 2 years now. Her retina doesn't look great on the photographs, but the vision is good enough for her to carry on her livelihood, and she can still work on her iPad, and she can do most of her work. There's a lot of laser being done, and so I would still say that there's quite a bit of role of laser, because she has had to had all these treatments, because this was a very severe case of refractory diabetic macular edema. But eventually they will settle down as long as you're working hard with your patients. There's another lady we had recently who had vision 618 in the right, 660 in the left, had a bit of macular edema which was lasered in the past, and the OCT showed a central involving macular edema. And this is, and the left eye started to swell up as well. And this was initially had 6 Lucentis, and then followed by moving on to aflibercept or Eylea, and a bit of laser for the focal treatment. And eventually she is settled down with a vision of 612 and 66. So for the take-home message is that when you're treating with anti-VEGF, our treatment strategy would be that we initially give them 3 injections and review them, but quite often we end up giving 6 or 7 or 8 injections before we actually give up on anti-VEGF. So that's the thing different with the AMD, where you have to consistently, you have to keep on hitting them with anti-VEGF and don't give up too early, as after a while you'll start finding the results coming through clinically. And she looks pretty good now. She's been stable for last few months. And what we sometimes used to do, and we not do it very often now because we have got ILUVIEN, we've got Ozurdex licensed to treatment, but there are occasional patients who are not pseudophakic, who are phakic, and we are not allowed to use steroid implants. And what I do is I take a canalog injection, I draw it up and put it vertically for about half an hour or 45 minutes. That helps to settle down the canalog. We throw away the solute on the top and take the concentrated canalog injection, the triamcinolone injection, and then inject. And that gives a much better and longer lasting treatment compared to just by drawing it up from a canalog normal standard vial. So the key points will be that if it is non-foveal involving, either you do focal laser, you can observe anti-VEGF for foveal involved DMO. Now, the one thing to remember is when the vision is good, all the studies haven't found Avastin to be inferior to either Lucentis or Eylea. So if the vision is still good, Avastin can still be the first line of treatment. Only the studies, the protocol T showed us that when the vision is poor, then you get slightly better results with, say, something like aflibercept or Lucentis. But if the vision is still good, if the center is involved, you can still go for the cheaper version. You can still go for Avastin as a first line of treatment. Patients for pseudophakic, we are more and more going towards using ILUVIEN in refractive diabetic macular edemas who are not responding or who are being stabilized on anti-VEGF but needing repeated injections. I'm not sure whether it's available in India or not, but we do get reasonably good results with using ILUVIEN. Apart from this, it's very important to control the blood pressure, the underlying diabetes. There is a role of PRP, as we said, like targeted PRP or peripheral if it's very ischemic. You have to rule out epiretinal membrane or vitreous macular traction, and the role of phenofibrates in diabetic macular edema, along with ruling out renal disease and controlling anemia. So thanks once again for inviting me for this talk.
Thanks, Dr. Nachi. For paucity of time, I don't think we'll be able to take any questions. I request Dr. Manish to come to his talk on surgery for DME and PD.
Thank you very much, Ajay, for the kind invitation. We've had some wonderful talks on the medical line of treatments, and I'll just briefly touch upon the surgical aspects of managing PDR and DME. And as you know, the most common indication is non-resolving vitreous hemorrhage or a subhyaloid hemorrhage over the macula, or a fractional detachment which is covering the macula or impending, or of course any sort of membranes or visual axis blocking those areas. And where the DME is concerned, you could have a chronic non-responsive edema apart from the various tractions that may be there either with membranes or hyaloid or epiretinal tractions which may be there over them. So this is a classic example of a subhyaloid hemorrhage which is not resolving and is a dense one. And when you see this, you already know that you actually don't need to wait too long on such a thick one, which is probably under the ILM, which is taut and it's partly over the subhyaloid, partly ILM. All these layers sometimes go hand in hand. So here you see that we are trying to peel off the hyaloid to create a space, and as soon as we removed some tissue, initially we thought that was the vitreous whole hyaloid which was lifting, but then I think in this particular situation it's like a schisis. You peel off a certain thickness of the vitreous and still there's tissue beneath that. So that's why the blood doesn't release itself. So now we realize that we need a deeper plane, and then you can see that now I'm trying to pull off the hyaloid in toto, and you see the blood underlying gets free from that area. Fortunately, subhyaloid blood is something which does not clot, and it tends to, once you peel off the hyaloid, it's in a free space and aspirates very easily and clears off, and it's actually very simple once the hyaloid is off. So this is one of the most common indications that the vitrectomy in PDR and DME is done for, and of course followed by any resolving any of the bleeders by diathermy and doing a good PRP at the end of your surgery. Then the next indication would be basically a non-resolving vitreous hemorrhage which has proliferations and hemorrhage which is there. It's for some reason not playing. Anyways, and before you go in for vitrectomy for DME-based things, you need OCT findings to make sure that you know you're in the right plane, and also to rule out the FAZ increase, which we were discussing with the angio-OCTs as well. Nowadays, we have those, but otherwise, the fluorescein, of course, tells you. So you also know the prognostic implications if you take those patients for surgery, if they have a traction at this phase or not. So when you look at these membranes or traction over the macula, nowadays, most of the times we are using the cutter itself, because the cutters have become so fine, and the ports are so close to the shaft end that you can actually go and almost peel them flush over the retinal surface and remove that traction which is coming in those areas. And then you don't need to always, if the traction, if there are spanning membranes, you sometimes don't want to touch the peripheral ones, because you know that will cause a lot of breaks in the periphery, and at times you just sort out the central part. If it's a one-eyed patient or something, you don't want to take those risks. So that was one such indication. And otherwise, of course, all these spanning membranes which you see, what I typically do is try to find planes between these membranes, try to dissect them, or rather cut them with a cutter, segment them, get them all separate instead of taking it as a whole. You segment them and then tackle different segments and try and just cut them flush from the surface, which works fairly good for most situations. And as soon as you know there are bleeders which ooze out, you could raise the pressure, stop the surgery for half a minute, and then go in and diathermize those bleeders and do the needful. Now here there's a chronic edema beneath the traction which was there, so after doing that, we put perfluorocarbon just to give pressure over that area, so that we know that the retina is taut underlying, and so it helps you peel that ILM or the membrane which is underlying much easily in those situations. This is another situation where you have a chronic edema with almost forming a hole in this particular area. For some reason is not playing again. Anyways, we'll skip that. Another situation where there is a taut, again a membrane which is covering the macular area, and so again using the cutter we find a plane, and here we use another small technique which has come up with the new machines, the proportional reflux, wherein just to find the plane you insinuate your 25 gauge cutter underneath the membrane, and to expand that plane, some people use viscoelastics to create a plane. Well, here you just use the proportional reflux and just push some fluid, and that creates a plane which is good enough for you to kind of find a plane, expand it, and then segment that area. So here you see that there is some residual tissue which comes out when I do the proportional reflux, which is from the cutter, from the tubings which are there, and slowly the plane keeps forming and you keep on cutting and segmenting it. So this is a technique we use for such kind of spanning membranes over the macula, and then you segment and then cut them individually, and slowly you are able to clear off the whole area in a separate segmented manner, instead of trying to peel the whole thing, which sometimes is dangerous because of the iatrogenic pulls that we may cause in these. A lot of people follow either an inside out or an outside in delineation, and these techniques have been there for a long time, and as I said in some of the earlier cases, I don't follow a particular strategy. In a given case, I just see where I can find a good plane, and then try to use that plane either from the center or from the sides or segmentally in whatever form. But in some cases, the adhesions are not very strong, like a case like this which looks fairly full of a lot of membranes, blood and spattered traction which is all over the place. You clear as much of the vitreous as possible and try and find a plane in that, and then you slowly from the outside start seeing that there is a plane. As you start aspirating and cutting, you will find that there is a plane which will help you move that whole tissue from one side. So this is what happens here, that you can actually remove the whole tissue if you are in the right plane. If you're not in the right plane, sometimes the traction is very strong and you will create a lot of breaks. So, but it has to be done very gently under visibility, that you keep watching the retina underlying and you see how much is the stress you are causing when you use the vacuum to pull it gently, and slowly you keep assessing that yes, it is peeling off, then you kind of pull it. Otherwise you stop and and you could stop there and use your cutter to segment that area. But in some of these cases, you are able to take off the whole tissue in a circumferential manner. So here, an outside-in delineation kind of works pretty well. Chronic cystoid edemas is again a different ball game, wherein you have these chronic edemas. Again, I don't know, some of these are refusing to work. Anyways, this is another chronic edema where you can already see an old Ozodex kind of a sacrophage remnant inside. We've treated this patient multiple times. It also needs some more laser in the periphery, but has chronic edema which comes. A lot of Lucentis have been used and Ozodex have been used prior to this. So here we decided to go and remove the hyaloid and remove the ILM to help that process. You can see that how cystoid changes are visible here in this particular area where we are peeling the ILM. So here we use the finesse loop, which helps you easily delineate the margins of the ILM so that then you can peel it off easily. So once you have a margin, you use your forceps, and as would with any other condition, you use it. You can see the bogginess of the retina underlying, which is very different than how you peel a ILM from a macular hole or a ERM. And diabetics always behave differently, and at times they keep on breaking. The ILM keeps breaking in between as well. So at times it can be a challenge. But if you stain well and gradually remove it, most of the times you can get a good plane to take care of it. And then you had this flattening we got after the surgery, and we also put an Ozodex at the end of surgery because the last one was given 4 or 5 months back to Insinuant. So I think my time is up, so I'll stop at this level. Yeah, thank you.
Thanks, Manish. We would have loved to watch your videos, but I think we are waiting for a talk. All of you who are practicing general ophthalmology would be waiting for what Dr. Grewal has to say about cataract surgery and diabetic retinopathy.
Thank you, Dr. Ajay. After swimming in the vitreous for quite some time, let's now come back to the surface and see what to do about these cases who all of them will be needing a cataract surgery. And the cataract surgery in patients with DME is a challenge because of the reduced visual acuity. The cataract interferes with adequate examination of the retina, and it also makes the laser difficult. And these patients are known to have a progression of diabetic retinopathy as compared to non-diabetic patients. There is definitely a worsening of the macular edema after surgery. There is progression of diabetic retinopathy, and there can be anterior segment ischemia. It goes without saying that all these cases should have adequate glycemic control before they are taken up for surgery, because all these cases will have increased blood-aqueous barrier breakdown and increased VEGF, which are maximum on day 1 and then come back after 1 month. These are the cases where you have to work on the preoperative workup. You decide when to operate, what is your choice of procedure, do they need a separate post-op care, and what is the role of vitrectomy in these cases, as already has been shown beautifully by Dr. Manish. Preoperative workup, this presentation is more from a perspective of an anterior segment surgeon. In preoperative workup, it is mandatory to have a complete work of these cases, even if on fundus examination the retina appears normal. When to operate the intervention will depend upon the stage of the diabetic retinopathy and the extent of the cataract. The preference will always be treating the retina first and then going ahead with the cataract surgery once you have taken care of the retinal problems, except in a situation where the media is not clear enough and you can't see what is happening behind. That is the situation when you will do the cataract surgery first and then be very aggressive in taking care of the retinal problems. Is it necessary to take that? Yes, this is a case where one eye was operated before the era of the anti-VEGFs, and you can see the one on your left with worsening of the changes in the macula, whereas the second eye was operated after giving a pre-op Avastin, and you can see that the difference it is there. So it's without doubt that the retinal changes need to be taken care of first. Now, these are some of the situations which you may handle. You may have a patient who is undergoing cataract surgery, may have a DME which is non-centric, or it may be a center involving. It may be a case of recurrent or a chronic, or it may be a case who has already been treated DME or ischemic DME. In first situation, These are the cases where you can go in for a micropulse laser, wait for some time, and then go ahead with the cataract surgery once the changes are resolved. This is another situation where you can give anti-VEGF first, consider local focal laser if required, and then you can plan cataract surgery in these cases. And non-center DME cases, they are known to have increase or worsening at 16 weeks. So it is important that these cases who are going cataract surgery in diabetics should be kept on follow-up for a longer, much longer period of time, and they must be assessed at about 3 months post-surgery. And it is the pre-op anti-VEGF definitely prevents the accentuation of diabetic macular edema. In a situation where you have a central involvement DME, this needs to be taken care of first, and you have anti-VEGF available of your choice. You give anti-VEGF, control it, then in the post-op, depending upon what the requirement is, you may continue with the anti-VEGF or you may consider doing laser depending upon case-to-case variation. This is another situation where a patient has cataract, the media is hazy. Now in this situation, we'll give pre-op Avastin and then go in for a phaco-cataract surgery, and it should be followed by a OCT angio and then again aggressive management of diabetic macular edema. Please consider cataract surgery under the cover of anti-VEGF agents if effective laser is not possible and a close follow-up. Intra-op anti-VEGF is again a good option where you can combine the injection and the cataract surgery at one sitting and then have a close follow-up on these cases. If you have, this is one situation, there's a case presented with early DME and 612 vision. Patient didn't agree for the treatment, comes back after 2 years, there is worsening of the situation, had injection Avastin repeated again after 2 weeks, there is no changes in the macular edema, and these are the cases where you will be going on to the Ozurdex, intraocular steroids, and there is a response to intraocular steroids, and then this is the time now for going ahead with the cataract surgery in these patients. This is the same case where you see there is improvement in vision, and at 4 weeks he is much better. So consider Ozurdex in patients with DME when Avastin fails and effective laser is not possible. This is a situation where you do a cataract surgery and you have aggravation in the post-op period, especially it is a combination of CME and cystoid macular edema. These are the cases which will best respond to the intraocular steroids rather than the anti-VEGF alone. The last situation is where a patient has ischemic macula, that means the foveal avascular zone is increased. Now these are the cases where you will be going ahead with the cataract surgery, but these are the cases who need a proper preoperative counseling, giving them a realistic visual outcome, and then these patients should know that they are not going to have their vision normal, and then these cases need a close follow-up, and it will be a good idea to keep all these cases in the post on nifapinec because it has some role in preventing macular edema. So to sum it up, you may have a center DME which has never been treated. In that situation, you may do, you will have intra-op or pre-op anti-VEGF, control it, and then go in for cataract surgery. In a previous treated case which is resolved, you proceed with the cataract surgery and follow up them closely. If it is a persistent, then you have anti-VEGF or intraocular steroids, and then you plan for cataract surgery. As far as the choice of the procedure is concerned, it needs a good uneventful cataract surgery. The procedure depends upon what you want to choose. Femtosecond laser does have a role in these cases, and these cases must be followed with OCT and angiography. As a cataract surgeon, you need a support of a great retina department. That is the final key. All the cases, I don't think, as a cataract surgeon, I am geared enough to handle these cases. As far as the diabetic retinopathy is concerned, I would prefer all these cases, all our cases go to the retina department, and once they say, okay, go ahead with surgery, then we go ahead with the surgery. Thank you.